Dr. Dowd and Dr. Sy, thank you for this invitation. It's cold up here. So Dr. Park and I are from San Diego. I just checked, it's 10 degrees warmer. So what I've been tasked to talk about are cellular therapies. I'm going to focus on TILs, tell you about what TILs are and how we use them, but also talk about kind of some broader issues. And I hope to answer these questions for you. So TILs, what are TILs? Most of you know, but some don't probably. How do you deliver TILs? How do you make TILs? How are TILs different than this other stuff? I have patients come in and they want to get stem cells or they want to get some other cells. How does TILs fit in? And which patients are right for TILs? So there are a lot of questions right now. As we've talked about, the mainstay of therapies have been targeted therapies that Dr. Moyers was talking about, and then checkpoints, or these immune therapies that Dr. Sy alluded to. So cellular therapy fits into both. It's a targeted therapy because it's going for something on the cell, but it's an immune therapy because it's part of your immune system. So it's the ultimate targeted therapy. So again, you've seen some of these curves about where we are in advanced melanoma. And in the last 10 plus years, gratifyingly, things have changed. But we're still not completely there yet because, as Justin was saying, our therapies aren't 100% effective. There's lots of ways that cancer and cells try to get around our therapies. So this just alludes to we need more tools. We need more diagnostics. So all this effort continues because until we get to that day where there isn't melanoma, we have to keep pushing the bar. Another person that's devoted their life to helping out the world in melanoma has been Dr. Rosenberg, who's been laser focused for about 50 years on trying to get TILs to patients. And this his efforts started back in the 1980s and had to do some Herculean things such as, TILs die in culture, therefore I have to isolate IL-2 and commercialize IL-2. There were many steps along the way that we just kind of take for granted these days that he worked out at the NCI. And TILs for a long time and cellular therapy for a long time were looked at as kind of boutique, that the NCI was really the only place, National Cancer Institute was the only place that could do this because they had the resources to both handle the toxicities, which we'll talk about, as well as create these cells. But one of its goals was always to try to get it out into the real world outside the NCI. And that's starting to happen. And here's just a basic schematic of what cellular therapy or TILs looks like. So you have the generic stick figure patient who has a lump. That lump is nice and accessible, just sitting there on the arm, and you can remove that lump. And when you look in that lump, it's cancer. But cancer is made up of a lot of things, such as the cancer cells. But then cancer cells need blood vessels and stromal cells. And in there are the immune cells. Some tumors don't have a lot of immune cells infiltrating in. Melanoma is one of those inflamed tumors that often does have a lot of immune cells. And in that set are T cells. You can take that tumor, and what they did at the NCI was figure out how to culture tumor fragments, allow the cells to come out, and after some time, typically anywhere from 4 to 8 weeks, they would get a expanded number of the cells they wanted, and by culturing them with these stimulants such as IL-2 and antibodies against CD3, you could make literally a bucket full of cells. And then you give those cells, which naturally recognize the tumor, right? They came from the tumor. The only reason they were in the tumor was because they recognized it. then they give them back to the patient. Sounds simple? Not really. How has this been implemented? I'm going to talk about two data sets, one centered in the US. And while this is from 2020, I think it's relevant because this is something the field anticipates will be available, never know. But work that Dr. Sarnak presented back at ASCO looked at a commercial study and looked at the practicality and the results of getting cells out to the normal people, the non-NCI centers. And so how do they do that? As I mentioned, you take a tumor out of somebody, so you have the surgeon there diligently taking tumor out. That sample is sent off, in this case, to a central processing facility. There are some places that do this themselves, such as MD Anderson has a cell processing facility, and they have a homegrown TILs. But these are hard to maintain. And so one belief was always that we needed to somehow standardize this and centralize this to make it more accessible. And so the tumor was sent off, gets in an airplane, flies across the country, and then the cells are isolated after some time, again, typically in the weeks category. This itself is not a guarantee because not always do we get a product out of the surgical sample. So unfortunately, patients can go through the resection and not end up with a product. But with the centralized manufacturing and standardized processes, it gets up to close to 60 to 80% of the time, roughly, that you can get a product. Once you get confirmation that you have a product, it can be stored. It's not stored very long, typically, because the patient wants their product back. But you get confirmation that you have a product, then the patient goes in for chemotherapy. What? That's crazy. Why give chemotherapy? So again, for the last 3+ decades at the NCI, these steps have been more or less empirically determined that, for example, if you're giving back the cells, you need to get rid of the bad cells. And so the role of the chemotherapy is to open up a space for the good cells to come in, maybe get rid of some of the bad cells. Whatever it is, if we don't give the chemotherapy, the therapy just doesn't work. So chemotherapy goes in, it's given about a week before the treatment or the infusion. Then your TIL product is infused. Looks very comfortable, but that's a hospital bed because at that point, a patient's blood counts are lower because the chemotherapy has started to work. The cells are infused, and then they get some stimulant, interleukin-2, which itself has some activity against melanoma, but it's used to expand and make the cells work better. And then recovery and discharge. Typically, patients may be in the hospital for, if they got their chemotherapy in the hospital, they get their cells, they might be in the hospital for 3 or 4 weeks to receive such a therapy. So the data that was presented was from this cryopreserved cohort. So you can make product fresh, keep the cells going quick, get it into the patient. That's a logistical nightmare, right? And patients may not be exactly ready at that point, and oh, by the way, you have to give chemo a week before, and if your cells aren't ready, all of a sudden you give a patient chemo and they're not happy with you. So there's a good reason to have a cryopreserved product. And so this trial looked at the activity of this cryopreserved product and compared it historically to the fresh product. And fortunately, it didn't seem to decrease the efficacy at all to have a frozen product that could be shipped more easily and more safely for patients. And here you see these quote unquote waterfall plots where the bars that go down indicate that tumors have shrank. So tumor shrinking, that's good. The arrow bars off to the right indicate how long these responses last. And one thing about immune therapies is that it occasionally hits that home run where you have a treatment and then you don't need any more treatment. And whether it's interleukin-2 or the checkpoints Dr. Sai was mentioning, and these cells. So there are a proportion of these patients that appear to not need any further treatment after the cells. But it comes with a cost. The toxicity rate is 100%. So again, hence we do it in the hospital. And within that toxicity are various things, such as fevers and chills. Maybe the blood pressure drops and we need to give fluids to help people out. But it's across the board. And so not every place currently with the current technology is probably set up to deliver this type of therapy. So it would be a place like UCSF, where maybe they've given bone marrow transplantation, which is a kind of a similar process. But you want to think about probably in the short term that this is going to be at a specialized center. Unlike immune checkpoints, where sometimes toxicities can strike a patient months after the beginning of therapy or even months after the completion of therapy, most of the toxicities that are seen in cellular therapy happen with the therapy. So patients are in the hospital, and all those little spiky things on the left side of the screen are just indications of when things are happening to the patient that they wouldn't want to happen to the patient, like fevers and chills and stuff. But then you see following out months that there's really very little as far as toxicity going on. So how do TILs fit in with other cellular therapies? And I've just listed a few here. So people might have heard of CAR T cells. These aren't T cells that drive cars. These are T cells that have chimeric antigen receptors. So that's a different way to make a T cell recognize something. And there are FDA approved products out for other tumor types. And CARs have their pluses and minuses. I've listed some of the plus and minuses here. NK cells, natural killer cells. That sounds like a good idea if you're trying to fight cancer. Something called natural killer cells. And this one has an interesting advantage in that a lot of these products have to come from the patient. Well, a patient may not be in the best position to give a product, and there's time and processing, but NK cells have the potential to be what we call an off-the-shelf cellular therapy because they don't have to be autologous from the patient. They can be allogenic. Most of the time they are. BiTE and TRIKEs are things I saw going across the bridge this morning, as well as these antibodies that can be engineered. And themselves are not really cellular therapies, but they're an interesting idea and have led to a plethora of now products in both multiple myeloma as well as uveal melanoma. And these antibodies grab onto the tumor cell on one side and then grab onto a T cell on the other side and put them together. And that really pisses off a T cell. It doesn't matter what that T cell was meant to recognize. So that's one of the advantages here. You can just keep a T cell and keep it next to a tumor cell, and it will, it's kind of like a teenager, just kind of go crazy sometimes. And then CAR NK, now we're off, doing really fancy stuff where you can modify natural killer cells. And while before they weren't recognizing a specific epitope or antigen or a specific tumor target, now you can actually engineer them. And then you get into finally what my patients always ask me about, stem cells. So you can create these cells from stem cells. I mentioned I was going to show two sets of data. And the reason I'm showing this one is, darn it, those Europeans beat us again. because my understanding was, I think, February 1st was the approval in the Netherlands for cellular therapy. And it was from this trial recently published, looking at patients who had failed one prior therapy. In most cases, this was something like pembrolizumab or nivolumab, these anti-PD-1s. And then they were randomized, different than the other data set. So randomized to either get cellular therapy or they got ipilimumab, which can be given in the second line. And you'll see again, here's the response rates, the waterfall plots. So down is better, and each of them had responses. But it looked like from a progression-free survival, from the number of patients that were benefiting, that the cellular therapy was superior to the checkpoint in this population. So unfortunately, you still got that 100% toxicity. There's more toxicity risk with cellular therapy, and I listed off some of them there. So where do TILs, or where will they fit in? So they currently fit in on clinical trials. So there's still trials, and trials are looking not just in melanoma, but in other tumor types to do cellular therapy. What patients are right for TILs? Well, you have to have a tumor that you can resect. And currently it has to be a big enough tumor to have enough cells in it to start that culture and grow. So that's roughly like a walnut, not shelled walnut. So something like an inch of tumor. And you have to be able to tolerate the anticipated stress that this therapy is associated with. And so it's not necessarily for everybody. The NCI used to have a chronologic cutoff. We don't like to do this, but they would not do this to anybody over 65. Some places choose 70. A lot of places are not going to choose an age necessarily. It has more to do with kind of your functional age. So how well you can tolerate. When do you give this? Well, do you give it always in the second line? I'm not sure. Again, with the current technology, it definitely is helping a percentage of patients, but it's not helping everybody. Personally, I think we should probably exhaust our best current therapies first before embarking on this. So do you need to fail, ipilimumab, nivolumab? Do you need to fail relatlimab, nivolumab? Do you need to fail pembrolizumab? Do you need to fail everything before trying something like this? Or do it in the second line, as that trial in Europe was implying? You also should be recovered from the last thing we did to you. So if we gave you colitis or something else, we should get you kind of feeling better and probably not subjected to something, again, so stressful as TILs. So advantage, disadvantages, I think that some of them are kind of self-evident. It's complicated. That's a big disadvantage. And one of the things people are trying to do, I'll just jump to this side, is both work on those advantages. So if they work, let's make them work better. Let's try to select better cells. Maybe we can treat people before to induce some sort of cells. Dr. Dowd has a really interesting idea of injecting interleukin 12 DNA into tumors, and maybe that increases the diversity inside the tumor to get better cells. Cell modifications. And so this is TIL 1.0 right now. So TIL 2.0 could be to put things into the cells to make them maybe work independent of interleukin 2. So you don't need to give interleukin 2 to somebody, for example. And better expansion, kind of sucks to wait around for 3 to 5 weeks and still not have your cells, or never get them. So getting that efficacy up, and some of the things working on the toxicity. So hopefully that gives you an idea of where exactly cells are right now and some of the efforts trying to get them into people. So thank you.